us together, but also to the RHIS working group. I think, as Pandula has highlighted, these 3 case studies that you'll hear over the series of webinars, we feel are important for countries to learn from each other, but also in the current context of reduced funding for different surveys and different other ways of getting information and data to the right place. RHIS is an increasing focus of attention by many agencies, but also many governments as well. So we hope this series helps inform on good practices. And lastly, a huge thanks to the government of Sri Lanka for co-hosting and leading this work together with other colleagues in Sri Lanka. Thank you. And over to Jean-Pierre, who's the co-chair of the RH.
Thank you, Pandula, and thank you, Craig. I have not much actually to add to what Pandula have said. We are very happy actually to have this series of webinar started today, and with the 3 case studies which were actually undertaken with the support of HDC. But as Pandula said, that's not the end of the series of webinar. We are actually welcoming any case studies about the data use from the members of the RHIS working group and from others could be actually suggested. We have already a few in the series that will follow the 3 case studies that were undertaken in Sri Lanka, Laos, and South Sudan. I will stop here and leave the floor for the presenters.
Thanks very much, Craig and Jean-Pierre. So without further ado, may I please invite Dr. Pamod Damurukon, who will start off with the presentation of the Sri Lanka case study. Pamod, over to you.
Right, thank you very much, and hello everyone. Let me share my screen. Right. So thank you for the kind introduction, Professor Pandula. So I don't think we need any further introductions about what we are planning to do. So basically what we are going to do today is to share some insights based on the fieldwork and the stakeholder engagements that we did in Sri Lanka last year to learn more about routine health information systems data use based on a case study of maternal and child health. So for this presentation, I'll be mainly doing the slides, and then my colleague Priyanka will be joining in the question and answer session towards the end. Right, so this work that we did in Sri Lanka last year is published as a report. So in case if you, I mean, all of that, or basically a summary of what we did will be presented in the presentation today in the webinar. But in case if you want to know a little bit more about it, we should be able to, share in future the report as well. Right, a little bit of background about Sri Lanka in case if you don't know about the context around Sri Lanka, because routine health information system and public health is all about context. So Sri Lanka is a tropical island located in the Indian Ocean, which has a population which is close to 22 million. And when it comes to the broader context in the country in general, we have an urban, rural, and a estate population who are kind of located more around the tea estates that we have in Sri Lanka, especially in the central part. And then when it comes to the administration of the country, we have 9 provinces and 25 districts. And we have more than 14,000, as we call it, GN or Gram Nilgiri divisions, which you can think of like the villages, which is the smallest administrative hierarchy when it comes to governing the country. So about the healthcare system in Sri Lanka, Sri Lanka has a free healthcare system at the point of delivery, and we have a government healthcare system which is very prominent and mostly available to the public, and also we have private sector. When it comes to the healthcare delivery, we have it organized in 2 broader arms. One is the curative care sector, which is including all the hospitals, which basically provide for the sick patients. But the other most important component is the preventive healthcare sector, which provide community level services, which also include the maternal and child health services, which we have focused in this field study. So especially when it comes to the maternal and child health service, we have an entity called Family Health Bureau, special thanks to them for allowing us to do this field visit last year. And they are the ones who are kind of governing the RMNCH service implementation as well as data flow of the country. So what you are seeing onto the right side is this governing hierarchy. So we have the Ministry of Health sitting at the national level, and then we have the provincial, regional, you can also think of district in most of the countries. And then we have medical officer of health. This is very important to note, because I'll be mentioning an abbreviation MOH in this presentation. So in this presentation, whenever I mention MOH, it is not for the Ministry of Health, but rather it is for the medical officer of health area, which you can think of it as a sub-district level in Sri Lankan health hierarchy. And then we have two field health staff. Basically, it's the public health midwife and the inspector. So I will talk a little bit more about the team in a moment. And when it comes to the MCH, maternal and child health information flow, we have a very mature paper-based system which has been there for decades. So this is nothing new. So when we try to introduce a digital system to kind of enhance the efficiency of the existing paper-based system in 2017, we already had a mature paper-based system which is kind of cutting across all the levels in our health hierarchy, which I mentioned before. So the digital system that was introduced was based on the Digital Public Good DHIS2, and it is primarily an aggregate based system that we have for MCH data reporting. So this basically is the hierarchy that I showed in the previous slide, and as you can see here, the digital level data capture happens at this sub-district level. That is something very important to note. But however, at sub-district level, the data is captured digitally for the level below. So it's for all purposes, when it comes to imagining like where the computers are and where the digital data capture takes place for this aggregate-based information system, it's at the sub-district level. All right. So basically, as I have mentioned, we have this digital system based on DHIS2 ERHMIS that was implemented in 2017. And when it comes to the objective of this study, what we wanted to do is to understand how routine data informs monitoring, planning, and decision making. So we didn't really stick to the we not only considered the digital system but also the paper-based system, because it was a more of a holistic approach that we wanted to have and to observe based on the information flow. A little bit of history about digital system implementations in Sri Lanka, even outside of the MCH. So as you can see here, DHIS2 has been quite formidable, and it has been gaining momentum when it comes to the number of implementations as well as the scale over last almost now 2 decades, I would say. So initial introduction of the system happened around 2009, 2010. And since, as you can see here in this diagram, we had small implementations around 2010. And then from around 2014, we had larger implementations related to nutrition, tuberculosis, and then the advanced implementations such as this MCH information system. And we even had some major implementations related to COVID-19 surveillance and vaccinations, which are basically collecting data at individual level. So the country has potential and capacity when in capturing digital data at individual level. That's a very salient thing to highlight, especially when you kind of try to connect it back to the system that we have for MCH. Okay, let's talk about the key actors in the MCH data flow in Sri Lanka. So one main important person is the public health midwife. So this midwife is the frontline healthcare person. Of course, part of her duty is collecting data. But she's the one who goes from household to household, conduct clinics at MCH or maternal child health clinics at the field level, and also maintains registers. And that's actually, her level is the point where the data flow starts when it comes to MCH. And then we have this medical officer of health. So as I mentioned, it's an area. MOH area is a area, but each of these sub-district areas are manned and led by a public health medical doctor. So he's a medical doctor who has special training in public health. So he's the one who's leading this team, and in his team we have set of public health midwives, and then I will mention a few other staff who will be there under his team. And then at district level, which is one level up, we have a medical officer in maternal and child health care. So he is kind of like the district level in charge person for MCH activities. He also is from a medical background plus public health training. And then at national level, we have the Family Health Bureau, which has a set of experts in MCH and administrators and all that. And also when it comes to decisions related to scaling and national level implementations, that's the kind of entity that takes decision. So when it comes to data flow from bottom upwards, we have the public health midwife level, then MOH level, district and national level. This is kind of like how things are organized in Sri Lanka. Okay. So quickly, the team. So the person who's wearing this white uniform is the public health midwife. Actually, like what you are seeing is when we visited her office. So all of these midwives in the villages that they are in charge of, they have a small office. And that office also has some, as you can see, some diagrams, some charts, which are printed and pasted on the notice boards. And then this is the staff who are mainly at the medical officer of health level. So as you can see here, like this one is the key person, team lead. He's a medical doctor with public health training. And then we have public health nursing sister. So she is the one who's kind of like a supervising officer of all the public health midwives who are the field health staff. So all these midwives report directly to her for administrative purposes. And then we have this one who's kind of wearing a uniform which is somewhat close to a uniform that you may see in this region worn by police officers. So he's actually not a police officer, but he's a public health inspector. So he's the one who's in charge of mainly surveillance related things, food safety, water sanitation, observing mosquito breeding places and all that. And then we also have some data entry personnel to also support in some of the MOH offices. And at district level, he's the guy who's kind of like the champion, who's leading the team when it comes to operationalization, dealing with the sub-district or MOH levels. He's a medical officer of MCH. And then we also have a public health matron who's kind of like supervising the public health nursing sisters in the MOH area. And in some areas, not all the districts, we have a public health expert who's kind of like having a doctoral qualification in public health, also like the main expert when it comes to public health level technical decision making. Right, so the process that we followed, we conducted across all these areas, the PHM or the grassroots level, sub-district level, MOH area, then districts and national level. And we also observed something called district level review meetings, which we refer to as monthly conferences. And then we reviewed dashboards, templates, and workflows that country is following. And we also had discussions with the MCH teams at all the different levels. So the methodology wise, what we are planning to discuss again today, what we did and what we are planning to present is the data flow and data use at each level, and the data quality process, both manual and automated, and the review meeting structures that we had, and the digital systems that are in place and whether they are enabling or whether there are any constraints, and the feedback loops, which is like, so it's not like a linear flow. While you have a linear flow at each level, whether there are feedbacks going into the level below or a couple of levels below. Right, so let's observe, let's quickly go through the lowest level or the public health midwife level. So what we have observed is that, so basically at this level, this is the level where the data is captured. You have a couple of registries, as you can see here. She deals with a lot of paper forms because this is the primary point where the data is captured. So there are some registers that you see in any country. There are tally sheets. And of course, there is one form that is prepared, which gets sent to the MOH level or the sub-district level, which will be actually the ones that is entered into the DHIS2. So some of the good practices that we saw examining this flow or whatever the activities that are happening at this level is there are monthly meetings at the level above, which is what we refer to as MOH meetings. And in these meetings, there is review and performance appraisal kind of work that happens for most of, I mean, if not all the PHMs, for most of the public health midwives. So that way there's a bit of a supervision and reporting that happens as by means of a presentation at a meeting or a public conference. So that is a very good feedback mechanism, as well as it's a means of supervising or assessing the work that happens at the PHM level. And they mostly have high level of completeness when it comes to data. The timeliness wise also not so bad. Generally, it is very high completeness, a very high timeliness as well. And there is a strong supervisory support provided by their supervising officers, such as the public health nursing system. Of course, there are some challenges. One is they don't really use DHIS2 at the offices they have. So they don't, mainly because they have some infrastructure challenges. So due to that, they don't generally have direct access to dashboards unless they log into the dashboards at the MOH level. Then, of course, the other one is the continued reliance of paper registers. So there's a lot of papers that they are still dealing with. And due to not having the digital tools, they have limited ability to perform real-time analysis. And let's discuss about the level above, which is like the sub-district level, which we refer to as a medical officer of health or MOH level. So as you can see here, the person who's wearing this pink shirt is the leader. He's the public health medical doctor or the medical officer of health. And he's the one leading this monthly conference. So it's a monthly event. It's not just a review meeting. It's a meeting to discuss everything. It's not a data review meeting, by the way. It's not just for data. Reviewing the data or like the completeness and things like that. It's a very operational meeting. So there will be few other people from outside, like the agricultural officer from the schools, police. They are also coming there to kind of discuss some of the areas of public health concern in this meeting. By the way, it's not just for the MCH. It is for everything that is happening at the sub-district level. So they discuss about immunization, vaccination, food quality, and things like that as well. One very important thing is like they use the DHIS2 dashboards as well as directly drilling into the visualizations and sometimes even checking some data quality parameters like reporting rate summaries also, what we observed in these meetings. So they have some presentations that they are demonstrating in these events, which kind of has screenshots from the DHIS2. But however, if there's a very pressing matter, then they kind of dig into the system and pull up some visualizations, as you can see in this picture. And of course, they identify anomalies and do some validation. And I mean, even when it comes to denominators, not just the numerators, which are the reported numbers. And they use DHIS2 heavily at this level. I would say, like in the entire data flow, this level, I think like from this level above, it is more or less the same. But like at taking operational decisions, this level does it most using the DHIS2 data. So the good practices that we observed at this MOH level, they have locally developed dashboards sometimes. So in addition to the nationally developed dashboards, which are designed at national level, they also have some local dashboards that they have designed to be used based on their local data requirements. And they have predefined validation rules which are set at national level. And there is review of real-time dashboards. But there are some challenges as well. One main challenge is at the moment how it is configured. They can only see data from their area. If you are wondering why they need data from other areas, the main reason is the comparison. That's something that they always mention. We want to see where we are, and also we want to see how we are compared to the district or national standards, as you can say. And then there is this gap between paper and digital workflow mismatch, and there are some inefficiencies related to that. And when it comes to using some of the advanced tools such as advanced analytics and the maps and GIS, there's limited capacity because they are again primarily not from a very technical data science kind of a background, and they haven't really they can manage certain things, but like there's always potential for more capacity building. Okay, now let's go one step above, which is the district level. So now, as I mentioned, at sub-district level, they have a monthly meeting for reviewing data and to kind of take operational decisions. At district level, they have it every quarter. And also once a year, they have a meeting where the national level people come to the district level to review the data and to kind of see the operational practices related to MCH at the district level. So all these couple of mechanisms are happening here. And as I mentioned, like we have a medical officer of MCH who's leading the data validation tools and the overall guidance. And as I mentioned, there's a quarterly and annual review. and they kind of always relate it to different indicators to make sure are we aligning with the national level indicators and standards, and are there any abnormalities? If so, they will be closely communicating that with the national level and discuss around that. And at this level, generally, the medical officer of MCH is the one who's kind of leading the discussions. Like, for example, they have ad hoc communication mechanisms like WhatsApp groups and things like that to kind of share some information and anomalies if they note at district level, and to also kind of motivate in case there are some discrepancies or shortcomings in related to data in some of the MOHO sub-district level. Good practices, there are many, like of course they have structured templates and dashboards, and what you are seeing here is this national level, how to say, okay, it's a district level meeting where national staff comes and reviews. So this kind of events happen only once a year for each district. So this is where like the you have the sub-district staff also, so the national level people will come to this in person. Of course, during the pandemic, we saw something nicely because DHIS2 was used at national level. They used to conduct these review meetings online those days. But of course, there are some major advantages related to motivation and many other things why you need to have these physical meetings. So the national people come prepared because they can drill down and see the how the district and the sub-district are doing. So they come prepared, and then they kind of create a dialogue between the district, sub-district staff, so that they can kind of discuss some of the shortcomings as well as rooms for improvement. And it's as I mentioned, it's a joint review that happens with participation of all different levels of staff, and there are action plans that are developed from the data. Of course, there are some challenges, like for example, staff transfers. The one main challenge is these champions who are there because they are doctors, public health doctors. Still, like the way the transfer system works, they can still get transferred outside of this public health domain to the hospitals to do curative care. So that way, like some of these experiences that you gather doing MCH and immunization related qualification skills and experience, it get lost because now this doctor is going to serve for the next 4 years in a hospital, maybe in the outpatient department. So this distinction in how the health system is structured in Sri Lanka and the transfer system is kind of sometimes creating challenges, as we observed. And here also you have some limited access to national level data, unless of course in these kind of meetings you always can discuss with the national staff, but otherwise you have some challenges. Right. And then let's discuss about the topmost level, which is the national level. And you will also see like the background of the images I'm sharing is changing. Like, of course, this is a national event, so this generally happens in a major city. It can be in Colombo or a kind of a larger venue. But like this is where the national as well as district staff attend, and they discuss about some major challenges they have observed related to MCH throughout the year. And this happens biannually. There are 2 meetings, and this of course is a kind of exercise where you kind of detect some practices and some data changes, trends, and it informs the health policy and planning. So because this is national level, this is where you can take that kind of decisions about policy and planning, and this is exactly where that takes place. Some of the strong practices, of course, they use both strong manual and automated data quality mechanisms in creating and preparing for this particular meeting. You have dashboards which are kind of integrated into the review process that happens leading to these events. And then there is a structured feedback loop, which is not just during this event, it's a continuous thing. So national level has staff who will be closely communicating with the district and sometimes the sub-district level when required, it's mostly district, to provide frequent feedback about the data that they are entering. So some of the data quality checks and mechanisms happens at the national level, and they kind of, it trickles down in a very agile manner whenever required. So it's not just like a biannual event that we are talking about when it comes to national level engagements. Challenges, there are a few, like there is no national data use framework defined as such, but however, we didn't really notice this as a major challenge because like at subnational and district level, it is kind of happening really fine. But what the gap was mainly like dealing with the other departments and the different verticals that you have in the ministry. So there is room for improvement on that, and this is also kind of related to the data sharing that happens between the different verticals at national level. But at subnational level, this the kind of data use that we saw are kind of very impressive. But at national level, of course, because the MCH department generally takes care of the MCH workflow, but like there's always room for expansion. And then with the country's digital health blueprint implementation and interoperability effort that is happening, there is room for interoperability. And if you can relate back to the first slide I mentioned, this is mostly the community level data, right? Aggregated together. But we also have hospital admissions related data, and while there are some efforts in aggregating the or integrating this data, the hospital data flows into this. There is again room for expansion, and then there is room for expansion for clinical data governance, and then policy level access, like this is again for the higher level officials and the other verticals in the ministry to the dashboards are also kind of minimal. So lessons learned at very high level, what we observed is a strong local ownership, and there is also custom data use and dashboards. So the digital tool kind of facilitates that, and together, because there's ownership and there is access and there is room for creating these dashboards, it kind of drives data use at subnational level, something we have observed. And then there are routine review programs which kind of promote the culture of data use. Of course, because there is a practice that keeps happening every month. Even like if we have people who are kind of lagging behind, there is a bit of a motivation and guidance that is provided to them. And then of course you have layered data quality checks, both in the automated DHIS2 system as well as manually. As I mentioned, there is also feedback that is happening going into the lower level. And there is continuous capacity building, which is again led at national level by the Family Health Bureau as well as at the district level. Of course, system usability and indicator clarity directly affect the frontline engagement as well. Interoperability is something that there is a lot of room for expansion, because especially with the country's digital health blueprint, and they are going to come up with a centralized FHIR-based national e-health registry, which will be getting fed all the information coming from different data streams. I think in time to come, this will hopefully be better. But of course, it's a bit of a challenging exercise when from a technical perspective. In conclusion, Sri Lanka's routine health information system demonstrate a very strong decentralized system. While it is implemented nationally, there is a lot of decentralized involvement and practices that takes place. That's why I mentioned it as a decentralized system. There is a high level of completeness of data, which again is why it is becoming more usable with sufficient level of data quality checks. And there is a well-established review culture, which we observed especially at the district and sub-district level. Of course, with the improvements in access, governance, and interoperability, there is a lot of room for expansion. And together, in addition to MCH, all other data flows with regard to routine health information system can be enhanced with that. And experience that we gathered and what we are sharing now from Sri Lanka, we see a lot of importance and opportunity for other countries to learn from what we have observed based on this field study. So I would like to acknowledge all the help that is provided from the University of Colombo, Family Health Bureau, and the Ministry of Health, as well as all the MCH staff. They were wonderful, providing us access as well as sharing us insights. Prof. Yonbro, I'm not sure he's here, but he was the one who was guiding this fieldwork together with Prof. Pandula, and then his Sri Lanka for also facilitating this visit. With that, a big thank you for all of you for kindly listening. I think we can take any questions if you have. Over to you, Dr. Professor Pandula.
Thank you very much, Pramod, for that excellent case study presentation. Thank you for the team as well. I think we can move into a question and answer session based on the field work that Dr. Pramod has described. I think we are also joined by Dr. Priyanga. Priyanga, are you there?
Yes, I'm here.
Hi, Priyanga. Great to have you back. I know you are probably tired after having to travel for a few days to come back to Sri Lanka. Thank you for joining in. Please, may I now invite participants for any questions, any clarifications you would require?
Prof. Pandula, I'm already seeing some questions in the chat. Should we take few of them? Or?
Please go ahead, Pramod. I tried to answer some of it, but
all right, you have already answered. Okay, no problem. Sorry, I was just now checking. Yeah, maybe like I think Nora is there, so if you have anything else to clarify, you can always ask.
Nora, please go ahead.
Thank you very much. Pamud, I really enjoyed the way you went through this presentation and explaining everything. As you can see from the chat, I was confused about the MOH level and have since realized that it is the lowest facility level of activity, and the public health midwife is an outreach from that. The question I want to ask is, how is an essential indicator data set defined in Sri Lanka so that you only collect the necessary data?
Very good question, Nora, and good to hear from you. Again, I can answer, but we have the Family Health Bureau represented here, Dr. Priyanka. I think you put a lot of effort in making sure that we have the essential data set that is collected, so you can minimize the number of indicators that you're tracking at different levels. So maybe you want to answer, Dr. Priyanka?
All right, or you can start, Pamod.
Yes. So again, Nora, unfortunately, I don't really have the list of indicators, but again, based on the best practices in defining DHIS2 system. So in fact, like the introduction of DHIS2 and the activities that took place around that introduction was not just digitalizing or introducing a digital system. It was an opportunity for the Family Health Bureau in general to kind of revise the data flows that they had and the kind of indicators that they were tracking. So that ways they came up with different they have a set of national level indicators that they have mandated to be tracked at all these different levels, and also identified some very operational indicators that they have mandated that needs to be tracked and be present in dashboards at each of these subnational level. And in fact, another thing that they also do, so defining is one thing, and then they have also make sure that you have the proper the data elements in the data entry forms and all that, so that it can be captured and all the way visualized at the dashboards. But they also make sure that in their review meeting, they kind of provide them with the templates which includes these indicators, so it is not really missed, because otherwise what can also happen is like you will define it and then you will put it in the dashboards, but there is no there is no motivation or proper guidance coming to make sure that everyone is kind of collecting that data and it is actually being used. So they have also done that part as well. So Priyanka, anything else you want to add about like this the mandatory data set?
Yeah, actually, you explained well. Actually, the Family Health Bureau and the government, the Ministry of Health has clearly defined a set of sets of indicators to be used at each level. And also they have prepared a very detailed indicator dictionary, which consists of all the details about the denominator, numerator, from where the data is coming, the data source and everything for each level. So the entire data flow is targeted to build that set of indicators, so that actually even before the digitalization of the maternal and child health data flow, so these indicators was identified. So that was a very plus sign, and that was a big help to us to properly plan the digital health system. So I think we have answered the question.
Thank you. May I ask another question?
Sure, please go ahead.
Now, we know that every year or two, WHO/UNICEF come out with a new standard of what they want. An example is that it used to be ANC 4 visits. Now they're pushing for ANC 8 visits and things like that. So my question goes around, how often do you update your indicator data set?
Yeah, thank you very much. May I answer that question?
Please go ahead. Priyanka. No. You are
Yeah.
you are the domain expert. Please.
Yeah, that is very important and very timely question. Yes, I mean there are the internationally reporting requirements are changing time to time, and we in Family Health Bureau, so we usually review our data flows once a year. So that is our usual way. In the once a year, we review the new requirement, and we may drop some indicators if they are not using anymore, and we may add new indicators. So similarly, we will be adding some data elements to our data sets as well. So, and the other thing is, even though some international requirements ask, I mean, just to answer them, we don't totally change our data systems, because so we have our own targets and we need to report them. I mean, at the same time, enabling this international reporting. So the short answer for your question is, so annually we are reviewing our data systems and indicators. Thank you.
Thank you very much. And all I want to say is I admire you for the willingness to change when you need to change, because it's so often so difficult to get new data elements in and things like that. And it is definitely not an easy process. Thank you, gentlemen, for all your answers. Much appreciated.
Thanks a
Thanks,
lot.
Nora. Thanks, Nora. I think Ali, you were wanting to ask a question. Over to you.
Thank you. Thanks, Pandula, and thanks, Dr. Pamut, for the presentation. I have a couple of questions. One is, this is because of my ignorance, to what level electronic health records or electronic medical records are available there? And if they are available, are they linked with the health information system at the aggregated level or not? And then the other question is that has there been any plan or any activities or ongoing on digital data capture for DHIS? Because we know that it's a big and usually the most time consuming level and prone to error in data capture. So has there been any work on the on digital data captures? Thank you.
Thank you, Ali. Again, Priyanka, I think you are the best person to answer. The two questions are about EMRs and then what level the digital data capture in DHIS2 and the plans. You can mention about all the plans that you are having at the moment.
All right, thank you. Yes. So in Sri Lanka, we are in the process of, we have, at the moment, we have developed a digital health blueprint, and one of the main component of the blueprint is electronic with the EHR. So electronic health record is being developed. So if by now, at this moment, the electronic health record is not totally in action, but some parts of the electronic health record is being developed and will be planning to implement. So electronic medical records, if you consider, so in the main hospitals of the country, electronic medical record systems are running. And at the moment, we are facing some challenges regarding the interoperability, and also according to the guided by the blueprint. So the country is taking necessary actions to make sure the data across all the hospitals are synchronized and shared. So at the moment, as Pramod very correctly mentioned, we confined our MCX system into to capture only aggregate level data from MOH level, that is Medical Office of Health level, which is sub-national, sub-district level. So the plan is to go up. So we all know the challenges and the drawbacks of having a part non-digitalized, which directly affects this data quality and the efficiency of the data system. So as a solution, we have planned to move this electronic system up to the data capture level, or the level where the data is generated, that is the service delivery level, which is PHM level, public health midwife level. For that, we have planned individual data capturing. So we name it as ECHDR. CHDR means Child Health Development Record, which is a booklet at the moment, paper-based, which contains all the data, including immunization, development, growth, nutrition, everything about a child. So that is totally being digitalized as individual level data. And the project is currently planned and now at the development phase. And with that, most of these paper-based forms and records which are being used by public health midwives will be eliminated, and data will be automatically aggregated into the aggregated report from medical officer of health area onwards. So that is the plan for digitalization or the digital data capture at the public health sector, especially in the maternal and child health sector at the moment in the country. Pramod, I think you have something to add.
No, not so much, but I'm also seeing some experts from the health information unit in the Ministry of Health also joining. I don't want to put anyone on the spot, but feel free to unmute and comment. But just to fill in one more thing, so the EMRs are already being deployed. But as I mentioned, when it comes to our healthcare system, we have the curative, which is like all the hospitals, separate from this preventive health sector or the public health sector data flow. So the MCH or the scope that we have for this presentation is mainly from that preventive health sector. But we have the EMRs to certain extents deployed in the hospitals at all different levels. Even the basic level hospitals we refer to as divisional hospitals, which has maybe 1 or 2 wards and the OP outpatient department. They also in some areas already having EMR systems which are coordinated by the government. We have not so many, like 3-4 EMR systems which are used across the government hospital systems. So hopefully, given that the interoperability exercise, at least from an administrative perspective, should not be too cumbersome compared to some of the other contexts we have seen. Yeah, just want to fill that in.
Thanks, Pramod. I guess I see Jean-Pierre, you had your hands up.
Yes, thank you. Thank you, Pramod, for this excellent presentation. I'm very happy of seeing what's happening in Sri Lanka. But I'm wondering if you had the opportunity to look at what's happening during the review meeting, how problems are identified, how solutions are identified, how recommendations are made. If you had the opportunity to look at the plan of action that you mentioned, are they really based on the data analysis that was made during the meeting? How much it's looked at what has been done to actually, if the recommendations have been implemented, and how much they affect the data afterwards. So I'm just wondering, this part of the data use, which is really the decision making, if you have any information about that.
Yeah, very good question. Again, so let's I will try to recall one of the incidents. So when we were in one of the sub-district or the MOH level monthly conferences. So one other challenge we always have when we join these meetings is to kind of separate our role. As what are we, who are we? This is our qualitative research challenge as well. When we are doing academic research, is our role there, because most of us have always been part of this system implementation, and when you are there observing, you always try to the people there will always, when there is an issue, they will try to engage us, so we can't just always be a passive observer. But one thing I can narrate is, for example, there was one issue in these meetings where the medical officer, the public health doctor, noted there's a bit of it was related to a particular indicator that the trend is kind of gradually, it's not a steep descent, but a gradual descent over last 48 months or something, over 2 years. So then the obvious question that we always get is okay, it's an indicator, what's the issue? Is that issue, generally we feel about the indicator, is it the issue with the numerator, the number reported? So then they actually went through that and to see the numbers are just fine. And that's where there was a nice understanding they got by looking at the data, where they kind of wanted to, It's very unusual, but they wanted to look at the denominator. So the denominator was the population under care, and they realized with the pandemic and all the cultural and social issues and so many socio-economic issues that the country was having, that was their explanation, at least the assumption by that time. The birth rates have really gone down, so the population that came from the estimates was a bit of a concern. So this was spotted when they look at that denominator. So that was a really nice finding. And then because the other thing is, like, the district level people were also there in the sub-district meeting. So they quickly discussed about a plan of action. So what happened was there was informal discussion that took place to look at these denominators and then also relate it with the district level. And 2 days back, when we went to the district level, we asked the same issue with the problem from the district level people, and they were aware of this issue, and the communication has took place, and there was a plan of action. So that way, you kind of see it being more interactive, exploratory, and also a particular plan of action is defined. And also there are always minutes that they take of these conferences. So there's always the next when it comes to next meeting, even if it is missed, it will be reminded in the minutes to kind of consider and check what has happened as based on the observation that took place in the last meeting. So these kind of practices, I mean, these are some solid examples that we saw during our field visit.
Thanks, Pablo. John, I hope that answered your question.
Yes, sure. I just wondering if there is any template for this part of the discussion in the conference, templates for the recommendation and things like that, and the following monitoring of the implementation of the recommendation.
I'm not sure. That's a good question. I don't think there's a template other than they review it based on their minutes. Priyanka, is there a template for this plan of action? So it's just a usual follow-up process based on what they record.
Yeah, exactly. So that's a very good question. So, and that is good point you raised. So actually, if we take each review meeting isolated, so the issues are taken, the progress is monitored, and the suggestions are being done, and recommendations are made. So, what we observed was the continuity of observation. So, the monitoring the recommendations that they have implemented or not was not so strong. I mean, from review meeting to review meeting. So there's a link, obviously, but I mean, it was not very systematic. I mean, ideally, a review meeting should start with, okay, so these are the problems we identified in the last review meeting, and so these are our recommendations. Then how we will review how whether they have progressed. But actually, that was not that solidly implemented in our observation. During past 1 year, especially in 2025, we were thinking and planning of making this link strong and better. And we are now from 2026 onward, we have revised the review structure and to include this continuity of taking care of the feedbacks. And I mean, sometimes the recommendations may not give the desired output by the next review. It will take another 4 or 5 reviews. So that workflow is being implemented starting from 2026. And thank you very much for that very interesting and important question.
Thanks, Priyanka. I saw Preeti, you had your hand up.
Yes, Pandula, thank you so much. Dr. Pramod, excellent presentation. Thank you for sharing your case study. I'm trying to understand, you have a very good system going on there. And you have these review meetings, which we just discussed. Very rarely do we see RHIS data being used so effectively. I'm trying to understand, maybe I missed this during the presentation, how important is the contribution of capacity building of your frontline workers in the entire in the entire cycle of data capture, and right from data capture to data use. And how often are your workers trained? Because this wouldn't have happened without your health workers being trained very often on how to capture data, how to analyze data, and more importantly, how to use data.
Yes, that's really important, and thanks for asking that. Again, like I think the much of the credit should go to the public health system in Sri Lanka and the effort that has been put in digitalizing and introducing the digital system. Because like all these public health staff at different level, all of them before they come into service, they have a rigorous training program. So in their training program, they are kind of taught on basics about the public health, which also, I mean, in addition to the service delivery, data and the supervision monitoring is a part of them. So meaning like whoever who's in the system or have at some point of time got a rigorous training on importance of data, which is I mean, if I compare that with the curative care sector, I see, I mean, this is my personal opinion, I see a major distinction. When it comes to preventive sector, they are more geared about the data. That's something I observe. So they come from that background. And when you are, I mean, so they already have a defined pathway for in-service training while they are in the service at different levels to kind of get these kind of data-related trainings from time to time. I'm counting on Priyanka to share more detail. And before we kind of introduce these digital systems, there's a proper training that happens by national team. And in addition, there are some digital tools like LMS, learning management systems, which are available. Again, Priyanka's team at the ministry has done it. So they can log in and follow these courses. And I think there's a digital certificate also provided. Like this is for different areas, for capture, analysis and all that. So they have a very structured training. And then this public health doctor who's at the district level plays a major role in making sure this capacity is built and sustained at that level. So it's a kind of like a multi-level holistic approach that they have, which again is kind of contributing to the success we have seen in some elements. Priyanka, you have anything quickly to add?
Not very much, but I should mention we have a very good established supervisory network as well. So all the staff members from public health service providers, from public health midwife to upward, they have their own supervisors, multi-level supervisory level. So one of the major activity of these supervising officers is to continue make sure that the healthcare worker is gaining knowledge of the continuously. If there's gap, so they will take necessary actions. And it's a as Dr. Pramod mentioned, it's a multi-level approach. MOH office, Medical Office of Health office, is led by Medical Officer of Health, which is a fully qualified doctor and who is having a special training on public health. So he's a very good resource in training his own staff. And time to time, we are conducting some training programs at the national level, training of trainers when new health challenges come, though new training requirement comes through regarding the digital health system implementations. And also we have these methods as LMS, learning management systems, where major aspects of using digital health system is addressed. So those are the things comes into my mind. Thanks.
Thanks, Priyanka. That's just excellent. And I think we have reached the top of the hour. Let me please summarize some of the highlights of today's webinar. One of the things that I saw emerging from this discussion is how the RHIS data use have been institutionalized. And that has led to collaboration at different levels, from the PHMS level to district level, the national level, and how that collaboration has worked. So the system is there, it has been digitalized, but I think there is a culture of data use that has emerged through those systems, and that probably have been contributed by many factors, and the established mature data flow which has already been there, though it's paper-based, would have contributed a lot to that success. And also there was discussion around flexibility at the center in terms of looking at the key indicators, how it needs to be adapted depending on the emerging needs, and how the feedback loops are established so that it doesn't really is an isolated meeting or convening of meetings that takes place, but it's more of a collaborative data sharing sessions that has been taking place. So I think we have learned a lot, and thank you very much, Dr. Pramod, for sharing, presenting, and Dr. Priyanka for your contribution in the discussion, and also to the entire team who did the field work and supported getting this case study finalized. Once we finalize the case study, which is currently in a draft form, we will share it with everyone. It will be included in the HDC knowledge repository, which will be launched soon, as the revamped website will also be launched in probably a few weeks' time. So with that, with the hope of meeting you once again with another webinar related to RHIS data use, I will say goodbye on behalf of the HDC, and thank you very much for joining. Thank you, everyone.
Thank you. Thanks
Thank
a lot.
you. Goodbye.
Goodbye. Thank you.
Bye.
All good.